Prapti. I'm a resident at L.V. Prasad Eye Institute, Hyderabad. So starting with our case presentation for the day. A 72-year-old female came to the OPD with the chief complaints of involuntary move. Hello. Yeah, involuntary movements of the right eyelid since 3 years, which has the history of presenting illnesses. The patient was apparently all right 3 years back when she started noticing involuntary movements of the right eyelid, both upper and lower, which were initially not very troublesome, but have gradually progressed over past 3 years and now causing difficulty to her in her day-to-day activities. It is exaggerated when she is exposed to the bright light, and otherwise there is no relieving factor. Coming to the negative history, there is no similar complaints in the other eye. There is no history of involuntary movements of the face. There is no history of headache, nausea, vomiting, drowsiness, or neck rigidity. There is no history of usage of any long-term medications for depression or any antipsychotics. There is no history of difficulty of opening of the eyelids. There is no history of photophobia, irritation, or foreign body sensation in the same eye. Coming to past history, the past ocular history, she
Prapti, one second, Prapti.
Yes.
Yeah. Can you go back to the first slide? The first one. Yes. So whenever you're, Prapti, you can hear me clearly, right?
Yeah, yes.
Yes. So whenever you're taking a history of a patient, right?
Yes.
As you keep taking information, you should constantly keep trying to frame what possibly patient could have, right? So, you know, she's female, she's 72, she has involuntary movements of right eyelid. Correct?
Yes.
So based on this much information, what do you think it could be? What are your differential diagnoses based just on this much information?
So it can be idiopathic blepharospasm or benign essential blepharospasm, or there can be any foreign body or dry eyes or something that is causing her to constantly squeeze the right eye, or there can be hemifacial spasms or
okay, Prapti, which language does the patient speak?
Actually, the case I just had the Marathi.
Okay, so tell me one thing. Did the patient actually tell you she has involuntary movements of the right eyelid?
She would have told, the only thing I could think of that she could have told would be that the eyelid is opening and closing again and again.
Yes. So chief complaint is written in the language of the
patient.
The patient is not going to tell you involuntary movement of eyelids, right?
Okay.
Even in their language, they are not going to be like, without me being aware the eyelid is blinking. The patient is not going to think so much.
Okay.
Yes, it is one of us, right?
Yes.
Patient generally will come and tell that the eyes are suddenly closing and I'm not able to open them. So your chief complaint should show that you've communicated well with the patient rather than speak to some senior resident who's allotted you the case and you've got the diagnosis, right?
Oh, okay.
Okay, that's a fair point, right? So remember that.
Yes. Yes.
You should be able to communicate to the examiner that you have taken pains to speak to the patient rather than get diagnosis on a chit. Okay.
Okay. Yes.
And it's a good idea in exam to always speak in full forms, not in shortcuts, right?
Yes.
So, okay, she's on Macu Shield for eyelid problem. Okay.
Yes.
And when you mention she's on Macu Shield, how does she feel? Does she feel better? Does she not? Is there no change?
There's no change.
Okay. And now when it comes to history of present illness, you have directly jumped to a whole list of negative history. Is that correct? So in your history of present illness, what are the components when you ask HOPI? You have onset, progress, duration. Is that correct?
Yes.
So is this complete?
And the aggravating and the relieving factor.
Is this complete? What you've written in the HOPI, is it complete? So onset is going to be when it started, right? How did it begin? Progress. How did it progress? Did the intensity increase, frequency increase, right? And duration. So you need to mention all of it, like 3 years. What made her sit at home for 3 years?
Okay.
Why has she taken time to come to you? So those things are a little missing. And the other factor is there could be a factor wherein actually the spasm had increased so much that now she is unable to do her daily activities, because of which she's come to you. So always find out what has caused the patient to come to you at that point, or if they have been actually roaming around a lot of places. And 3 years she's on AccuShield. Why did she continue taking a medicine if it had not worked for her at all? Or did it work for her for some time and then the problem increased, or somebody has asked her to visit you for a second opinion, right? There are a lot of factors which are missing here. And the other important thing is whenever you have patient with these spasms, right? And history of cataract surgery, always ask that, did the cataract surgeon ask you to do something before the surgery? One could be they might have forgotten, some Botox might have been given. 2, most of these patients never have topical phacosurgery. They always will give some history of injections around the eye, some facial nerve blocks, etc., so that, the surgery is done at ease. So ask them some histories pertaining to that. Okay?
Okay.
Go to the next one. Okay, stop here. Now, forget what you've written. Okay? Based on whatever history we have, we think it is spasm. What is the most essential negative history in the entire history? Like if you're looking at history of present illness, past history, family history, if you just have to pick up 2 or 3 or maximum 4 things in negative history, what will you ask? Think and answer. Anyone can attempt this question in the audience.
Whether the other eye was also...
Good. Next.
Whether it is only the eyes or the face as well, like...
Okay, so unilateral, bilateral, I'm talking in medical terms.
Yes.
To any other parts of the face or neck. Okay, what else? We already discussed difficulty in performing the routine daily activities to know the severity of it.
Okay.
Right, what else?
Yes. Any long-term medicine usage, because they are also known to...
Systemic drug use, okay. Okay, but I wouldn't put it at the top of my list. Anything else in particular? History of dry eye?
Dry eye.
Okay, so history of dry eye is extremely important, and why? I'll tell you later once we start discussing, and if I forget, you're going to remind me.
Yes.
Anything else?
No.
Okay, go ahead. Next.
Coming to the visual acuity of the patient, both eyes, the distance visual acuity was 6.9, and this is a video of the patient.
Go on, I'm waiting for a commentary of the video.
So there are involuntary, spasmodic, repetitive eye movements of movements of the upper and lower eyelid on the right side.
Can you play that again?
And also the eyebrow area. With what appears as normal blinking.
Okay.
In between.
Okay. Can someone in the audience comment why do you think this is involuntary? I think Prapti mentioned it's involuntary. What if I say this is a voluntary thing, the patient is faking it? That is one question. And the other question I want somebody in the audience to tell me, comment on the video, the quality of video, any comments. It's good, it's not that great. Just give me a basic comment on the video. Either I point out or is someone going to volunteer? Make your mistakes now, not in exam, trust me. Make all the mistakes you want now. Fight your nerves now. Who would like to go on? Just unmute yourself and start speaking.
Dr. Nikhat?
So we are going to choose, is it, Anuj?
We need
Go on,
to
go on. Just tell me. I mean, what do you think of the video and the patient? I mean,
Ma'am, the pupil is dilated and I can see a glow from the eye, and I think it is involuntary movement because the old patient faking this kind of thing is rare, I guess.
you underestimate patients a lot, don't you? And you've
The
already
whole
shown your
patient-
interest in being an intraocular surgeon. The first thing she noticed is the dilated pupil. I didn't even notice that. So, all right. And what do you have to say regarding the video?
Ma'am,
The whole
uh,
page should have
Ma'am,
been-
it's
Ma'am,
unilateral.
facial expressions, facial spasm tics we cannot appreciate in this video because only eyes are visible.
Okay. Okay, that's a good point. Mohammed Fahad Javed, yes. You were saying something?
Ma'am, I'm saying it's a unilateral, not bilateral. If patient would have been faking, then he should present himself as a bilateral condition rather than unilateral.
That's a good point, but the more and more I practice, I realize that patients, I mean, they outsmart us at times. So yes, considering her age and all the conditions, there's a likelihood this is definitely not fake. But the interesting thing is, can you play the video again, Prapti?
Yes.
You notice something very weird. Look at the forehead.
Hmm.
In the orbicularis, what are the depressors of the eyebrow? Can somebody answer? Somebody who hasn't spoken till now. What are the depressors of the eyebrow?
Dr. Aishwarya? Dr. Ruchika? Anyone? Dr. Amber?
The answer is right there in front of you.
Dr. Sonali? Anyone?
Come on, Sonali, tell me, what are the depressors? Yeah, who spoke right now? Go on, whoever's volunteered. Otherwise,
ma'am,
Sonali, yeah. What?
corrugator supercilious,
Okay, and?
Procerus.
Okay, and?
levator palpebral superior, LPS.
Interesting, but no.
Frontalis.
It's interesting thought, but it is not.
Depressor
Orbicularis oculi.
Supercilii.
Orbicularis oculi, you have the corrugator and you have the procerus. These are the main depressors of the eyebrow. What are the elevators of the eyebrow?
Frontalis.
That's it. That shows the imbalance, right? So again, look carefully. Play the video. The reason why I'm saying this is not voluntary. Look at that. It's a very, very weird movement. When her orbicularis is functioning, right? Actually, her procerus and corrugators should also be active. But her frontalis is active the same moment when her orbicularis is functioning. This is really very weird. It's very difficult to mimic this movement voluntarily. So 100% this is involuntary. And the other thing is, when you're talking of facial tics, you need the video as a whole. 2, the video is not centralized. 3, of course, ideally video should be taken on a tripod, but many a time my own videos are not on a tripod, but these are things you need to sort of remember. Prapti, let's go next, please. Go on. Yeah.
So the external examination, the external face showed involuntary repetitive movements of the eyelids and the eyebrows of the right side. The facial symmetry was symmetrical. The external face was normal. The ocular position was normal. The HBT was central. Coming to anterior
Yes,
segmentive.
skip this. Next. Okay, next.
So provisional diagnosis for the patient would be right eye benign essential blepharospasm and left eye squamous papilloma and both eye pseudophakia.
I still want to know how much should you analyze dry eye in this patient, and what would you like to do if you had an opportunity to go back?
So I would have wanted to do a Schirmer's test for the patient. Look at the upper tarsal conjunctiva, lower tarsal conjunctiva. Do a tear film breakup time test for the patient.
Okay.
Do a fluorescent stain and see if there is any pattern which favors dry eye.
Okay. So this
And
patient did not have any lower face issues at all?
No. Actually, this was a video sent by Dr. Anuj to us on the WhatsApp group. And
I got that.
Yeah.
Okay. Anuj, there was no lower facial movement at all, is it? Anuj is busy, I guess. Yeah, Prapti, you were saying, okay, Prapti, your answers are fair and valid, but when you begin, start with something very simple, right?
Okay.
Always ask for history of, is there intermittent watering, burning sensation? The other thing is look at the blinking rate.
Okay.
Look at the tear film height. So start from there when you're watering. Don't directly jump to Schirmer's test and everything.
Okay.
It's the same rule that follows for examination. You start with inspection, then palpation, right?
Okay,
so
correct.
Just get that thought process a little cleared so that you don't fumble in exams, right?
Okay.
So what would you like to do? Look at the tear film height, compare between both eyes. 2, look at the blink rate. Right?
Okay.
3, this is something clinically I'm telling you. Generally, patients with dry eye also tend to have terrible lower eyelid skin quality.
Okay.
They'll have a skin with dark circles and skin will be very dry and fragile. And then you move on to the other tests. Like you can have, what can you have? Tell me. Schirmer's test, yes, and
tear film breakup time.
Yes, sir. Anuj, you were showing the video, right? Yeah, can you just repeat it, please? Prapti?
Yes.
Yeah, tell me everything you're seeing and thinking. Can we?
There's also spasm of the levator and levator near the lateral angle of the mouth as well.
Okay. Anything else? What about the other half of the face, apart from the papilloma? Anything else that you're seeing?
The
muscle wasting on the left side.
Excellent. Who was that? Ah, wonderful, wonderful. So all of us have certain degree of facial asymmetry, don't we? Right? So whenever you see patients, especially pertaining to oculoplasty, you need to defocus from the eye, look at the face as a whole. So 10 to 30% of asymmetry is physiological, and even though the video is taken from an angle, I would say that the right side of her face overall is a little larger than the left, but it's still within physiological constraints. Now, the other thing is, if you look at her forehead, the suprabrow region, it definitely like. What happened? Did I miss something?
अभी नया स्टैटिस्टिक कुछ पता है कि जब यंग लोगों में बहुत ही कार्डियक स्टार्ट होती है.
Your what? Okay. So the suprabrow region appears to be a little full right here.
yes.
So there could be two reasons for this. One being her facial asymmetry. So when you have facial asymmetry, the side of the face that is larger, everything is large. The bone, the muscles, the ligaments, all of it. The fat component, all of it. So don't forget that. Large doesn't mean just muscle bulk is more. So definitely her supraorbital ridge is a little more forward on that side. Two, the other reason is this muscle is getting a workout. It's almost like going to a gym because of the spasm. So the muscle automatically, when you start working out a muscle, what happens, Prapti?
Hypertrophy of the muscle.
Yes. So some amount of that happens. That is where, of course, we'll go back into the discussion of Botox. One advantage of Botox is that just like you've gone to a muscle and build up your muscles, right? And then suddenly you start relaxing, what will happen? The muscle tone goes down. The amount of muscle fibers, they suffer a breakdown. So repeated use of Botox also helps in reducing the strength and force of these spasms. Yes, Prapti, what next would you like to do for this patient? And what's your diagnosis now? You've given me differential diagnosis. So can Nishat Rana Sheikh, can you tell me what your final diagnosis is? If Nishat is not there, maybe Heather can speak. K, Heather, Nishat, if both of you are not there, anyone? Asma, Mohit, Ruchika, Wazir. Yes.
Hemifacial spasm.
Hemifacial spasm, right? Your answer is not complete. So it's a right-sided
Right-sided hemifacial spasm.
Hemifacial spasm, right? So the duration is 3 years. So the patient has not had any treatment so far, apart from AccuShield, right? So Wazir, how would you like to investigate her? What would you like to do? And how are you going to counsel her?
Ma'am, kindly ask again.
What are you going to do? You have a patient with hemifacial spasm. You've diagnosed her. What now? What next?
Ma'am, in hemifacial spasm, first thing is first thing is if there is a dry eye, we will one is general and management, and the other is specific management. In general management, if there is a feature of dry eye, we will treat the dry eye. And in hemifacial spasm, we normally give Botox injection.
Okay. Prapti, would you like, once you know the diagnosis, you've seen the whole video, would you like to go back to your negative history and past history and ask her something else? Anyone can answer this question.
If there is a weakness of other side, like of the same side of the face, if she's able to close the eyes completely.
Excellent, excellent, beautiful, beautiful.
I would like to rule out Bell's palsy in this patient because one of the cause for hemifacial spasm is compression of the facial nerve because of at the cerebellopontine angle because of the dilated blood vessels.
You know, you lost me there with the second line. So the thing is, patients with Bell's palsy can have abnormal reinnervation of the nerve that can give rise to hemifacial spasm-like or even absolutely weird spasmodic syndromes. Hemifacial spasm, one of the theories behind that, go on, tell me the theory behind it, which you're already halfway through.
Is irritation of the facial nerve.
So that is unlikely, that is going to irritate the nerve. So if a nerve is getting hyper, it's not going to go into paralysis, right? Right? So post Bell's palsy, a patient, because of abnormal reinnervation, can develop slightly atypical spasms on the face that can mimic hemifacial spasm, or even certain syndromes like, you heard of crocodile tears?
Yes.
What are crocodile tears? Somebody other than Prapti? Anyone? Anyone? Just volunteer and take a guess what crocodile tears are. Yes, Wazir. Wazir, you unmuted yourself. Yeah. Would you like to answer?
No, I have no idea, ma'am.
It is shedding of tears while eating or drinking because of
those are, yes, abnormal
reinnervation.
Abnormal innervation from superior salivary nucleus.
Yes. So it's important to know that both these concepts are a little different, even though Botox does work in both, right? Now, okay, I want somebody to attend this. Prapti's answered quite a lot and prepared well. I say that this is a Meig syndrome. This is not hemifacial spasm. Who's going to have that argument with me and prove me wrong? Yes, Wazir. You've all seen the video. Do you want to see the video again? Heather, AK, Amber, then Mohanad Aldur. Yes, there are a lot of people here. Just speak up, speak up. You have less audience today. Speak up, attempt it now so that you never forget. Generally, when you give a wrong answer to a question, you never forget it ever. Isn't that right, Anuj?
One thing I'll like to add, because I don't know much about this, just for residents, that we should avoid using the word Botox.
Oh, yes, 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 100%, 100%.
Yeah, just for
We are going
residents.
to get into that, absolutely.
Yeah, after the exam, you can definitely,
Yes,
that
you
is the
have
only
to,
word which you have
it's
to
an
use.
extremely important point that he said. Just Botox is again the brand name given by company allergen to botulinum toxin. When I mention you should not use short forms, it's the same thing. Because currently allergen has lost its patent to Botox. So a lot of companies have, I mean, the patent expired basically. So a lot of companies have come up with their own version of Botox, and we have many options today. So yes, would someone like to tell me why I'm wrong in calling this a Meig syndrome rather than a hemifacial spasm?
There will be involuntary movements of the tongue also associated with jaw, like orofacial.
Are you sure
problems
it's
will
of
be
the
there.
tongue? Okay, what happens in Meig syndrome?
Yeah, Dr. Irene, you can answer this.
Can someone tell me what happens in a Meig syndrome?
Go.
So hemifacial spasm, we have clarity, right? It involves one half of the face. When we have both upper half of the face involved, what is it called, Prapti?
Benign essential Blepharospasm.
Excellent. What if the entire face is involved? Bilateral, upper half and lower half of the face is involved. What is it?
Meig syndrome.
Yes. Right? And say, these are the most important things. So a young boy comes to you age 25. Prapti, this is for you. And he's complaining that his left lower eyelid keeps on twitching intermittently. And it's disturbing him. It's causing him to be very conscious during office meetings, etc. What do you think he has? Just the left lower eyelid twitches intermittently.
Orbicularis myokymia.
Okay. What are the precipitating factors for orbicularis myokymia? Are you going to inject him with Botox? He's 25, healthy, sits on the computer for 10 to 12 hours a day.
I would like to rule out dry eyes in this patient.
Okay.
Because of computer vision syndrome. And
if
it is very, if it is hampering the day-to-day activity very significantly, then we can try a focal Botox injection. Like, I'm not sure, but.
Okay. The first thing when you have myokymia, your diagnosis is right. Myokymia is most commonly stress-induced, right? But apart from stress, there are certain other factors like irregular sleep habits, dehydration is a very, very common factor precipitating myokymia. So rule all of those out, and undiagnosed refractive error can give rise to some degree of eye strain. What happens when you have someone with astigmatism and is not wearing glasses? They will constantly tend to slit their eye. Have you seen those patients?
Yes.
To see better at the lower line for distance, they will slit their eyes. So automatically you're causing an orbicularis workout. It's constantly under stress. So at times that also can precipitate. So do not forget to rule out refractive errors in patients with orbicularis myokymia. Only if it is very disabling after all of the stress management, lifestyle changes, food, diet, exercise, all of it, if adequate water. If nothing works out, or for the interim, you can consider injecting Botox. And in these patients, it's a good idea to sort of balance it out. Otherwise, Botox unilaterally can give rise to differences of articular pressures. Now, botulinum toxin. Let's call it botulinum toxin before Anuj points out again.
I'll share one video if you can.
Yeah.
Yeah. So
Yes. Please go ahead.
1 second. Yeah. So I think my screen is visible, right?
Yeah.
Yeah.
It's a beautiful video. Beautiful. Very nice. Thank you so much for that.
Yeah. So I thought we were talking about it. So just.
Yeah, that's really nice. So while we're discussing this, can I show you a few short videos regarding Anuj? I can go ahead.
Yes, definitely.
Yeah, I'll show you some video regarding spasms, and I need you to be interactive regarding this. Okay, you can see my screen now.
Yes, it is visible.
See, this one's pretty clear, right? What is this?
Not yet playing.
Can somebody answer?
Video is not playing.
I want you to observe all these videos very closely. I'll play them again for you because after this, I do not want you to have any doubts regarding spasm. Remember, in exam, you might be given a blepharospasm and somebody might call it a hemifacial spasm. And you can goof it up in exams. So do not do that.
Dr. Anuradha, we are not able to see the videos.
So that one, the previous one was very clearly, what was it? Someone? Sonali, what was the previous video?
Dr. Anuradha,
Was
we are unable to see the videos actually.
Ma'am, we have not seen
And
the
I need
video.
someone to describe this particular video.
Ma'am, the video was not playing on the screen.
Heather,
Dr. Anuradha.
anyone? And
I think she we are not able to see the video.
if nobody else, Anuj.
Yeah. I think
Prapti, go on.
I think our speaker is down.
Prapti,
I'll have to call her, I think.
I'm still audible, right?
You are audible, but video is not seen.
Anuj, I can't hear you.
Okay. 1 second.
Yeah.
Yeah, we cannot see the video.
Oh, you cannot see the video, is it?
Yeah.
Oh, wait.
Yeah.
I'm sharing the video. Why can't you see it?
We can see the screen, but we cannot see the video playing.
Is it?
Yeah.
Okay. Wait, let me play it again. You can see the screen now? Facial spasms?
Not yet.
Okay, let me share it again. Now?
We can see the screen.
Now?
But we cannot see the video.
That is really sad.
I think you need to minimize this window of this Explorer.
Okay.
Yeah, just try and see, because maybe video is playing in the background somewhere. No, we cannot see.
No, because this thing is minimized.
Acha, here we can see your Windows Explorer only. We cannot see the video.
That is really weird.
There is an option of advanced sharing. In that, you'll have to select video.
Wow.
Advanced sharing, is it?
Yeah.
Yeah. When you go to share screen, there you have one arrow which will give two options.
Okay.
So you are getting that advanced sharing options.
It is requiring me to install some plugin or something.
Oh,
Anuj, let me do one thing.
right.
I have this particular thing on a drive, right?
Okay.
I'll just share that thing with you. While somebody just start talking of differences between Meig syndrome, hemifacial spasm, blepharospasm.
And Dr. Irene or Dr. Minu?
Anuj, just send me your email until then.
Okay.
Can someone answer?
Ma'am, hemifacial spasm involve one side of the face, and in
Okay.
blepharospasm, both of the eyelids are involved in mostly bilateral in blepharospasm, but in hemifacial, it is usually unilateral. In Meig syndrome, as we have discussed, that the upper whole of the upper part of the face or the lower part of the face is involved.
Okay. Anuj has shared that your answer is right.
Okay.
So make sure that you keep looking. Anuj, if you have got the drive access, can you play those videos one by one?
I'll just check that.
There are 4 short videos there. So that is important. And now, what options do all these patients have apart from Botox? Hemifacial spasms, do they have a surgical option?
They have a neurosurgical microvascular decompression option.
Excellent. But would you recommend that over Botox?
No.
No, no.
Why? Why?
The surgery would be very risky, and the age, considering the age of the patient and the.
Okay, that's a good thing. The other thing is not only the complications, the
Vascular complications for the.
Yes, the complications. One good thing about surgery is that it's a permanent cure. Botox has to be repeated, right? But the thing is with surgery, it has to be proven angiographically that actually functionally they can see the artery and the nerve, crossing over and the irrigation. Anuj, it's opening? Yeah, great. You can everyone see this?
Yes, ma'am.
And what's the diagnosis here?
Orbicularis myokymia.
Look at the entire video, take your time, look at it. What is?
Hemifacial spasm.
Excellent. Who said hemifacial spasm? Yes. So hemifacial spasm can present in different severities, right? So here he's got a very subtle one, but if you look at the corner of his lip and his cheek, you're actually seeing the movement of the zygomaticus major, right? So keep looking at the corner. So this is a hemifacial spasm. The severity is not extremely intense in the lower half of the face. Anuj, can we go to the next video? Remember, in exam, look at a patient and make your diagnosis. So how do you precipitate a hemifacial spasm in your patient? They're not going to have it all the time, right? So you have a patient, you barely have a few minutes with them, and you want the spasm to precipitate. What are you going to do then? A simple thing in exam is to, if the patient doesn't have active spasm at that point, ask the patient to clench their jaw and close their eyelids really tight. So when that happens, ask them to hold it for 5 seconds and repeat it 5-6 times. Automatically, in 90% of the patients, that will precipitate the hemifacial spasm. Now, can somebody describe what is happening here? Go on. We don't have a long time.
Benign essential blepharospasm.
Okay.
Spasm.
Anything else? Okay. This is benign essential blepharospasm. Yes. Somebody said lid something.
Lid apraxia.
Excellent. What is lid apraxia? Tell me.
Inability to open the eyelid.
So what does she have? Blepharospasm or apraxia?
I'm a doctor from Jordan, Jamal Dania, inside the University of Arkansas. Just a nephrologist. Bro, it took me like half an hour to find her email.
شو اسمها؟
Well, she's Nadi. ف
نادية شو؟
بعرفش بس the university gives H1B visas. I won't saw them كلهم Indian doctors.
Prapti?
Yes, ma'am.
Yeah, tell me, does she have blepharospasm or apraxia?
They can have both, right?
Excellent, excellent. So how do you know which is which? Okay. So generally, classically, trust me, 90% of the non-oculoplasty doctors find it very difficult to catch apraxia. And it's a very, very fair point. Very, very fair point. Early apraxia, even most of the oculoplasty surgeons can also miss, right? So in a blepharospasm, what you will notice is that the patient, the blinking rate will be high. Now, in between the high blinking rate, if generally apraxia is always associated with blepharospasm, but there are very rare cases wherein you actually have a predominant apraxia component rather than a BV. So when the patient suddenly closes the eye, takes a second or more and then opens it, you know it is apraxia, and the history will clinch the diagnosis. You ask the patient, what is the trouble? So they will tell you that my eyes keep closing, but even the blepharospasm patient is going to say the same. But you ask the patient, what do you do when your eyes close? A blepharospasm patient generally will not do anything. They'll just keep voluntarily trying to fight it. An apraxia patient is going to do this. The moment they will show you that action, trust me, 99.9% of the time you've diagnosed apraxia, which is hidden with a blepharospasm. Now, the thing about apraxia and blepharospasm, none of us know the exact mechanism of apraxia. Botox cures, temporarily relieves most of the blepharospasm, botulinum toxin, but the apraxia component can be unmasked by a botulinum toxin injection in a blepharospasm patient. So the patient will tell, my eyelid has stopped twitching, but they are still closing. So most of apraxia patients, they still will be a little unhappy with after the injection. But having said that, the weakening of orbicularis that botulinum causes allows them to open their eyes a little more easily. Now, can someone tell me very roughly what happens to levator and orbicularis when you open and close your eyelid normally, like in a blink? Not the tight closure of spasms, like in a blink. What is going on? The nerve supply to muscle wise. And levator is not a depressor of the brow. Okay. The only function of levator is, what is the function of levator?
It is to lift the upper eyelid.
Yes, that's it. That thing only does that job, right? So what happens when you close your eye to the levator? Okay, to make things very simple, in very, very simplistic terms, the mechanism of blinking is actually very complex. There are too many pathways involved in it. So when you open your eyelid, the levator, the third nerve that supplies the levator, is on and it opens up the eyelid, right? Levator contacts the eyelid, opens. When you close, there is a switch off button for the levator. So when the orbicularis is turned on, the levator turns off. We are not exactly sure what pathway is causing it. There are multiple papers in relation to that. So that is the reason the pathways of apraxia are believed to be somewhere involved in the pathways that also help in these switching on and off of orbicularis in levator. And that is the reason Botox also does not work there, because it's a switch on-off mechanism rather than having a overactivity or a spasmodic contraction of a muscle, right? So now Mohammed has mentioned myectomy. Now orbicularis myectomy to some extent does help in apraxia by reducing the amount of muscle fibers that give rise to this particular pathway, abnormal pathway that does not allow the orbicularis to be turned, the levator to be turned off. Is that somewhat clear? Prapti?
Yes, ma'am.
Okay. Anuj, can we have the third video?
Oh, yeah, one second.
So I want someone to diagnose here. Just turn off your, unmute yourself and answer. What is this? Anyone? Quick.
Left-sided hemifacial spasm.
Excellent. Why is it not a Meig syndrome or some other facial dystonia?
Meig syndrome.
Yeah.
Ma'am, in Meig syndrome, as we have discussed it may involve the whole of the upper part of the face or whole of the lower part of the face. But in this case, only one side of the face is involved.
But and she has a very strong component in the lower half of the face, right? Now, what are the lower half of the facial muscles that can get involved in hemifacial spasm? Can you continue answering that question?
Zygomaticus major muscle.
Okay, and? Okay,
Levator,
apart from that, yes.
Levator labii superioris aliquinesi and mentalis.
At times, yes. And at times, you could also have a risorius component, right? So when I injected the same amount of Botox in this particular patient, it didn't work. I had to inject a few more in the lower point. So there are no fix. You have to keep titrating each patient depending on the muscle bulk and the problems before you inject. And if you notice, she has a few bands on the neck. But those bands are platysmal bands because of age, not because of spasms, okay? Can we have the fourth video, Anuj?
Yeah, it is actually buffering. Let's see.
Okay.
Yeah, I'll just share it.
Who wants to take up this particular case? Take your time, we'll play it again. And sorry, none of them have been done on a tripod. They were patients I had seen elsewhere. I didn't have a tripod handy. What does she have?
Meig syndrome.
Why do you say that?
Meig syndrome.
Apraxia with Blepharospasm.
With what? Would anyone like to differ? Go on. We don't have very long.
The upper part of the face is involved, bilateral upper part.
You think it's only the upper? Look at the right lower half of the face and a bit on the left also. The right, it's more prominent. So you're right about it. She actually has a Meig syndrome. In fact, it went even beyond. She had a bit of platysmal spasms as well. And here, this is a very classic thing that apraxia patients tend to do. So she's got Meig syndrome along with apraxia. Is that clear? So these patients are going to require a lot of Botox. It's important to do an imaging in which patient of all these syndromes?
Hemifacial spasms.
Yes, excellent. Because at times you could also have certain tumors in the head that could press on the facial nerve nucleus that give rise to these problems, right? So in apraxia, if you had to do a myectomy, what sort of myectomy would you do it? What are you going to call the myectomy? Mohammed, you answered myectomy. What sort of myectomy? Myectomy means muscle removal, right? Which muscle are you going to remove if the patient has apraxia? And Botox, she's not getting enough relief with Botox then. Yes, Mohammed Javed. You answered myectomy. I agree, it is rarely performed. Whoever is online is free to answer.
Dr. Shiva?
Orbicularis.
Yes, Dr. Wazir.
Sir, orbicularis.
Yes,
Orbicularis active eye.
orbicularis. Yes, orbicularis. Now again, there are 2-3 different types of myectomy. At times a pre-tarsal myectomy is done, at times a complete orbicularis myectomy is done. There are various schools of thoughts. What will happen, Wazir? Orbicularis ko nikal diya. What will happen to the patient?
Apraxia. There is a apraxia. There is spasm of the both the upper and the lower lid.
In an apraxia patient, you removed orbicularis. What are the things to be kept in mind in the post-op period? What do you warn a patient about? What will happen if in any individual you remove orbicularis?
Exposure keratopathy. Exposure keratopathy.
Lag of time.
I've removed orbicularis. So how will ptosis happen? Lag of
Exposure keratopathy. Exposure keratopathy.
Lag of thalamus, basically, right? The blink is going to be incomplete. So automatically existing dry can increase or new dry can be created. Now, this is extremely important for you to remember. It's a fairly recent research, and there's extensive research going on in this area as well. There is a concept specially pertaining to benign essential blepharospasm. It is called as entropion of the meibomian glands. It is exactly what the name suggests. The researchers, the current doctors who are basically have made this observation and studying it, Dr. Ramon Malhotra is one of the main people there in UK. He observed that most of these patients who come with blepharospasm, they tend to have a mild entropion of the meibomian glands and significant amount of dry eye with a slowing of the oil glands in the eyelids. So the meibomian gland keeps rubbing on the eye, and that also causes a lot of irritation. So he believes that there also is a slight amount of added component of a spasmodic entropion in these patients because of that. So the moment he sort of elevated the eyelid, like pushed it so that the meibomian gland orifices are turned away from the ocular surface, the patients found a significant relief. So now, along with Botox, he has been doing an entropion correction for these patients, just so that the meibomian gland orifices are completely away from the ocular surface, along with significant amount of lubricants. And there has been a significant amount of difference in the symptomatic relief of the patients, as also in the severity of the spasms. So do not forget to look at dry eye in detail. And if, as a student, you look at the meibomian gland orifices, whether they actually, it's not a frank entropion, like the textbooks describe, you get it? It's just a meibomian glands are slightly inside. They could be associated some mild rounding of the posterior margin as well. It would be an excellent find, provided your examiner keeps himself or herself up to date with the research. If you feel that is not the case, please do not show off in exam. It is perfectly okay to say, I don't know, and do not rub egos in the wrong way. So now, what is botulinum toxin? And where are you going to inject it in all these patients? At what level do you inject it? And how does it act? Very quickly. We are just going to take 3 or 4 more minutes. That's it.
Man, in essential blepharospasm, we inject at 4 sites. One in normally one in upper lid at the lateral side at the lid margin, and one at the lateral canthal side 10 mm away from the lateral margin, and 2 injection at the lower lid. Okay. And we normally inject 12 to 16 units in case of blepharospasm. In hemifacial spasm, we normally
how many units did you say for blepharospasm?
In blepharospasm, normally we 12 to 16 units.
12 to 16.
Ji, ma'am.
Okay, I would advise you to cross-check your references regarding the dose, because blepharospasm generally requires close to 40 to 50 units of Botox for relief. For hemifacial spasm, you would actually require anything between 17.5 to 25 units of Botox. Now, neurologists inject Botox as well as oculoplasty surgeons, right? So the neurologists tend to inject slightly higher doses and at quite deep levels compared to the style that we oculoplasty surgeons follow. So if you look at files of neurologists that the patient gets, for hemifacial spasm also they have been injected with 45 to 50 units of Botox. This is a different style of injection. So for all purposes oculoplastic, we could easily answer 15 to 20 units for hemifacial spasm. And for blepharospasm, you do require 40 to almost 45 units in most of the patients, right? For apraxia, at times we increase the component, we add an extra point on the upper eyelid in the center, but in the pre-tarsal orbicularis, not the pre-septal. What will happen if you inject in the pre-septal orbicularis? What are the possible complications that you could foresee with the use of Botox in all these patients? Botox does act for approximately 3 to 4 months in most patients, but the duration does keep varying depending on the physical, physiological factors of the patient, stress levels, all of it. In the same patient, sometimes the same dose of injection can act for 4 months, and during some stressful period in their life, it can act for 2.5 months. Yeah, you can answer the question.
The complications are ptosis. Is the
that is if you get very close to the orbicularis. Do you think, Wazir, important question, do you think the good injector will induce ptosis? An experienced injector, do you think a patient could have the possibility of having a droopy eyelid ptosis in the hands of a good botulinum toxin injector?
No, ma'am.
Trust me, droopy eyelid happens to each and every surgeon. Certain patients are just extremely sensitive, and all of us who inject Botox have come across at least 1-2 cases of droopy eyelid after Botox. Now, what do you do? A Botox with droopy eyelid, what are you going to do? Generally, you just observe. The best part is the effect goes away. We say it goes away in 3 months, but trust me, most of these eyelids just come up in hardly less than a month, right? Now, who started using Botox in human beings? In history? Anyone?
History, ma'am. Normally, the Botox was using for the in the eye for paresis, muscle, extraocular muscle paresis, but accidentally it was injected in the lateral canthal area, and it smoothens wrinkles. After that, it was come into use for cosmesis.
Do you know the ophthalmologist who first started using Botox? This is important. His name is Dr. Alan Scott, and he started using Botox in squint patients who he couldn't correct beyond, who couldn't get corrected even beyond 2 or 3 surgeries. So he would use Botox in order to get the eye in the primary position. Now, it's important that we are having this discussion today on 12th of December. He died on 16th of December last year when he was 89. So he sold off the rights of Botox to Allergan. Now, after he started using Botox for strabismus, a lot of doctors started using it for migraine and cervical facial dystonias. When they started using it for those, they discovered that the skin on that area suddenly is wrinkle-free and is aging quite slowly, and that is how the cosmetic use started. And approximately in the late 1980s, FDA approved it for use in various other aspects. So today, what are the different brands of botulinum toxin that you have heard of apart from Botox? And what type of toxin is Botox? There are many types of toxins, right? Produced by Clostridium.
Type A.
Yes. Why type A and why not type B or E, F, G, and whatever?
Type A has a longer duration of action.
Type A is most potent. That's the most important one. It's the most potent injection. Now, the thing is, there are many brands available right now. Commonly in oculoplastics, we end up using either Botox, which is by Allergan, which was the first one that came out in the early 90s. And the other one is Xeomin, which has come out some years ago. So both of them are type A. In fact, the other brands also like Botox from Dr. Reddy's and Stonox, they all are type A. What varies is the molecule size and the components and the accompaniments with it. Those vary. And based on that, again, and the diluent you use, the action, modality, and the duration that it stays in the patient also varies. So do you think one should mix and match, say one time I have injected a patient with Botox, second time can I use Xeomin? Should I do that or should I not do that? What will happen if you keep using Botox continuously in the patient? What is the possibility? Will the action stay the same? Will it keep increasing? Will it keep decreasing? And why?
Continuous use of Botox usually leads to development of antibodies in the body.
Okay, it is believed that in some patients, and how do you know, is that the duration of action of Botox keeps on reducing in the patient as time goes by. So that's a possibility. Antibodies, what are the other mechanisms? Sprouting of new nerve endings and upregulation of receptors. I'm not going to get into extreme theories here of what is Botox and what are the chains and everything, all that you can read in textbooks. Now, the thing is, what has been noted in recent literature is that Xeomin tends to act a little longer in many of the patients, and quite some of us are sort of preferring Xeomin unless and until the patient insists on Botox alone. And at times we even keep switching between them just so that the body doesn't get used to the same thing, right? So what is the one prescription that you will write to every patient after Botox injection? What are you going to write in the prescription after Botox? Lubricants. As simple as that. Lubricants. Extremely important. Extremely important. You have to be very careful with patients who have nocturnal lag and lagophthalmos. Important to add some sort of a lubricant gel as well at night for those patients, right? So apart from that, regarding spasms and everything, clinical findings, history, what are you supposed to write? If you have any doubt, we can take 5 minutes and answer your doubts. Any doubts or? Can you see my screen? Is my screen visible? Anuj?
Yes, ma'am.
Okay.
Yes, ma'am.
I don't want to take up too much time. Just remember a few points. Allen Scott, strabismus, types of Botox. These are just points for you to remember, which can be asked in exam. Trust me, if you reach this discussion, you have passed the case, okay? So very quickly, I'll just take you to this thing, right? You need to know what are the few different types of Botox available in the market, right? Who's the manufacturer? Not much. Remember that botulinum toxin type A is the most potent. Xeomin is manufactured by Merz. And of course, antibodies is the most common. Important. Contraindications. Do not forget the contraindications of Botox. Now, the reconstitution is done in normal saline, not in distilled water. One has to inject it very carefully so that there are no particulate matters. And frothing, the molecule is very fragile. One should not allow too much frothing and air to enter. Otherwise, it can destroy the molecule and reduce the effectivity. Clear? So depending on the dilution per unit, the dosage can change. I generally tend to use 2.5 units in 0.1 ml. So this are the approximate doses. And there are certain other indications for which the examiner can ask you what are the other conditions in ophthalmology where you can use Botox. You need to remember those. Chemical tarsorrhaphy, if you cannot do tarsorrhaphy in a patient, in say certain corneal conditions where you want temporary basis, droopy eyelid or ptosis, you can use Botox for that. Spasmodic entropions, again, this can help in. Why will we inject Botox in the lacrimal gland? Can someone answer? Prapti? Why would anyone want to inject botulinum toxin in the lacrimal gland?
Frey syndrome?
Good answer. And the other thing is, in certain patients, when there is excess watering because of some reason wherein we are unable to or not able to proceed with any surgical options, it's a good option to inject lacrimal gland. Generally, by the second or third injection, patients are symptomatic and relief-free. Now, while these points have been marked many a times, every injector do have their preferences regarding the points. Generally, apart from ptosis and lag of thalamus, the other effects that are written here, they generally do not happen. Hematoma can happen if you hit a vessel in a patient who is on blood thinner. And this is a simple chart for you to remember. One eye, it's generally orbicularis myokymia. One half of the face is Blepharospasm. Upper half of the face, bilateral Blepharospasm. Whole face, Meig syndrome. Brugel syndrome if it's Meig with the neck muscles. Is that clear? I think I'm done from my side. Parkinson, yeah, I think Anuj has put in a question. Parkinsonism as a differential diagnosis. The Parkinsonism classically will have a pin-rolling tremors, but there have been cases reported wherein the patient with Parkinson's can have associated problems such as these. Now, most of these patients are first most likely going to go to a neurologist before they come to you. And generally, once they go to the neurologist, the entire Botox and everything is going to be taken care of there. But if you see a patient with pin-rolling tremors, etc., be a little careful before injecting Botox. It's always a good idea to get a go ahead. Most of the time, the Botox you inject in the face and the muscles, they do not go anywhere else in the body. It should not cause any problem. But still be a little careful, especially in patients who have asthma, myasthenia gravis, any muscular dystrophies. Always be a little careful when you're injecting. Yeah, any questions? I'm done from my side. Anuj, anything else you want me to cover?
Ma'am, I have a question.
Yeah.
Ma'am, one thing you were telling that the Botox dose is like it's around 40 for the essential blood.
Yeah. It's a 40 units, I meant.
Yeah. But ma'am, it's written in the Gansky, what I remember, it's like 10 to 15.
See, it could also depend on the dilution of it. So in the dilution that I mentioned, we end up using 40 to 50 units in practice.
Okay. Do we give it in the multiple, I have seen a patient who has just received the Botox injection. Within 1 month, he just has the essential Blepharospasm again. I think within 1 month. And he is typical of the Meig syndrome.
I think the doctor who injected might have referred Kansky.
Sorry?
The doctor who injected might have referred Kansky for the disease.
Okay. Okay, now I get it. Okay, and my question is like, what type of the doses do you prefer to give it?
What type of?
Doses. You were saying we can give it in the doses and is spastic ectropion or entropion.
Yeah, doses as in to induce doses. Say you want temporary doses and
you want
to do a tarsorrhaphy, it's a good thing. If you think there's a corneal condition that requires some tarsorrhaphy for a couple of months, instead of that, you can just inject some Botox directly in the levator and actually cause a chemical ptosis.
Okay. And my next question is like, you are inducing the ptosis, and how much do you prefer to just decrease the aperture of the eyelid, eye, or you just do the partially, you are just giving it the Botox to just induce the half partial ptosis for that?
That's an excellent question, Heather. Now that the extent of ptosis required is determined generally by the corneal surgeon, because these cornea patients generally end up requiring that. So we ask our cornea colleagues what they require. These patients do not approach oculoplasty surgeons directly. So we leave that to the discretion of the anterior segment surgeon.
Okay, ma'am. One more last question. Sorry.
Just one second. If they want complete thing, then at 2 different points, we can inject approximately 2.5 to 5 units. That is going to cause complete ptosis. If they want partial, then we generally inject it at a slightly different zone. Yeah.
Okay,
Yeah,
ma'am. Last question. Can I?
Yeah, please go ahead.
Yeah, ma'am, my last question is how much in squint you were saying when the patient has received multiple surgeries in one eye for the squint and where still the eye is not in the primary position. When you inject it into the intraocular muscle, what should be the dose of in the intraocular muscle?
That's a lovely question, but I do not do that because I'm not a squint surgeon. But generally, as far as I know from my squint colleagues on whatever little I might have read in that matter, I think they inject approximately 5 to 7.5 units. And, yeah, that's what they generally tend to inject, but then it differs a little. Oh, there's one more recent research. You can hear me, right, Rosie?
Your voice was breaking up because of some.
Oh, sorry. Heather, you can hear me now? You can hear me now.
Yeah, ma'am. Yeah, ma'am. Yeah.
So it varies a little. I believe it is 5 to 7 per muscle, but maybe a squint surgeon would be better to answer that question. That is 1. 2. Recently, I think Dr. Alan Scott had some years back published a paper wherein, or I think very recently, I was just reading up actually before we started. They found that injecting bupivacaine strengthens the contralateral muscle. If you've given Botox in one muscle and you want to strengthen the other ocular muscle, bupivacaine strengthens muscles by certain mechanisms. It facilitates formation of muscle fibers. So that is a research maybe you guys can read a little more into and even update me and Anuj regarding that. So they've been playing around in squint with that. I don't operate squints and yeah.
Okay, ma'am. Thank you.
Thank you.
Ma'am, you had asked me to remind you about, you were going to tell us something about the dry.
Yeah, that thing, the meibomian gland entropy.
Okay.
That thing. And by the way, if your examiner again gives you a Kansky-esque answer regarding how much Botox to inject, if they correct you, just nod your head, okay? Just nod your head. Keep the examiner happy. The examiner is right.
I have a question regarding this meibomian gland entropy. Does that meibography helps us in that case?
Meibography will help you in a way of knowing how far the meibomian glands are active or not. Meibography is not going to help you understand the exact placement of the meibomian gland in relation to the ocular surface. That is something you physically have to do and elevate it. Even your CT MRI is not going to give you that. You have to physically see it on the slit lamp.
Thank you.
Is that all? Anuj, I think we are done.
Yeah. I think if anyone, any more doubts?
Thank you.
Sir, please make arrangements of such Zoom meetings again.
Absolutely. Now, because it has been such a lovely session and good interaction, and Dr. Anuradha was really busy, but we had to really convince her. So it was really nice that she could share the videos. And I think today we had residents even from Pakistan and consultant from Jordan also joining. So it was nice.
Oh, wow. That's quite an honor. Hello to everyone from Pakistan and Jordan.
To them, Dr. Wazir.
Thank you.
Oh, I see. How wonderful is that? Anuj, thank you so much. I didn't thank you for giving me a very kind introduction. That was incredibly sweet of you. Anuj and I go way back. We know each other from LVPI days. Thank you. And you guys have been so interactive and wonderful questions. It got me thinking as well. And yeah, thank you.
Thank you, ma'am.
Okay. Good night. Thank you, everyone.
Thank you so much.
Thank you, sir.
Okay.
Thank you, sir.